Uh, Dr. Asha, unmute yourself.
Yes, sir. Namaskar. I welcome you all to this joint meet of Society of Fetal Medicine and Raipur Obstetric Gynec Society. This meeting was suddenly conceived when I attended Dr. Ashok Khurana's talk in a society of Jharkhand group. And I thought that why not have something similar here? And I was in correspondence with him for the last 4 months, and finally we see the fruit. We have a plan now where we will be discussing clinical topics on obstetrics and gynecology, on obstetrics, ultrasound, in association with Society of Fetal Medicine. So we have the president, Dr. TLN Praveen, the secretary, Dr. Ashok Khurana sir, who has been the past president and even now means he is my point of contact at the present moment. Dr. Hasmukh Lal, who brought SFM to Raipur, Dr. Mohit Shah, Dr. Aparna. I welcome all of you and I request Society of Fetal Medicine to take over and start the proceedings of the day. Dr. Khurana sir.
Thank you and a very good evening to all. It's a pleasure indeed to actually be here today in Raipur, if I may say so. We now are as comfortable with the virtual medium as with the real one. And we've suddenly realized that we do a lot more academic work in the short time that we have for a virtual meeting. And the one thing that some of our people have pointed out is that, sir, all my questions get answered and no one's in a hurry. I said, that's because we have good people who coordinate. And the person you see right on top of the screen there is Dr. Hasmukh Lal, who was actually the brains behind making sure that we had an Odisha chapter, that we had a Chhattisgarh chapter, that we had a continuing chapter in Calcutta and so on, that we are here today. And we do our programs differently. As Dr. Krishna Gopal will tell you, we encourage programs at different levels. And when Dr. Asha told me that she would like people to understand what it is being on the same page, how a sonologist, a radiologist, a laboratory, and the practicing obstetrician really should be speaking the same language, and that we do not do so. And so we better get going with our work and make sure that we are actually saying the same thing, understanding the same thing. And we said, okay, so we'll go ahead. And so here we are today, the first of a series that will be there for you on the first Wednesday of every month. And I'm really happy. When I suggested that we should do this and go ahead, Dr. TL Praveen said, of course you must. I said, it's a whole year's program. He says, no, Ashok, you must go ahead and let's see what we can do. And I said, okay, so we took the plunge. And so we start off today's program. And thank you everyone from the Society of Fetal Medicine to be here, and Dr. Chinmay for joining us. Who is currently not on our executive committee, but has been there right since the beginning. And we look forward to a series of talks. But before our talks begin, a presentation by Dr. Krishna Gopal on how the Society of Fetal Medicine runs its continuing professional development programs. Dr. Krishna Gopal, please, he is our executive secretary.
Thank you, sir. And very, very good evening to all of you. I was an opener in my school and college days. So once an opener, always an opener. So this is how we will start, and we will start our executive development programs. So I'm just trying to share my screen. Just a minute. Give me a second. I think my screen is shared now.
Not yet, sir.
No,
Not
we
yet.
can't see you.
This is fine.
Yeah.
Okay. So
we're still not sharing your screen.
I think you unshare and again share it. Then
Yeah.
Okay, just a minute. Let me unshare.
Very much sharing, yes.
Thank you so much. So COVID has done many bad thing to us, and we have lost people also. But SFM has grown leaps and bounds during this period due to our online connections and online teaching and local chapters whom we are after for so many years. They get activated. They took the initiative, and I take pleasure in saying that with every meeting we are getting better. So, this is one thing that I will keep first in my list. So every local chapter is now very much active, and those are not active, they are still thinking to get active, and they are now in that active mode. So, all of our local chapter meeting has started, and these standards, because these are telecast to throughout our nation. So, the standard of these meetings are quite high, and there are, in every meeting we get at least 500, 600, 700 attendees. So, everybody is looking forward for this local chapter meetings, and that is perhaps our biggest achievement of this period. Second is our post graduate awareness program. We have done our two steps. First step was conducted with the Jharkhand RIMS and the Patna AIMS, and second is with the with our uh, 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 Calcutta chapters. They are actually taking all these West Bengal medical colleges in it. Third is Journal of Fetal Medicine. Journal of Fetal Medicine. Initially, we were a struggle to find that we should get good papers, but now people are quite active, and they are sending us good papers, good case reports. And I think that the biggest hallmark is when we are discussing all these things with the aid of technology. And we must thank our YouTube channel for it. I get regular queries that please put these lectures on our YouTube channel. Please put these lectures. So we are looking forward to put all the lectures you want. We please give us views and suggestion, so that we can put all these things in our channel, YouTube channel, that is quite active nowadays. As sir told us that we should be on the same page. So we are working with Foxy and other associations to bring them on the same page, because until education is something that should be shared, until we shared it, we are not going to achieve our goal of optimal outcome of the fetus. We are also working on the guidelines of Indian orientation, because many of the guidelines are there as a world perspective, but we are trying to mold it according to our local needs. We are also activating our SFM smart app that has already two calculator in the form of MCA PSV mom and mean PI uterine artery. We are also looking forward to add many more calculators in it. We are also working upon our first trimester quality program that is online, because of the COVID, the pandemic situation. And Dr. Tiran Parveen sir is working upon it, and we are very soon uh, 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 launching it in its online form. So, again, congratulations to the Raipur chapter for organizing such a nice meeting, and there is a way to go ahead. Thank you so much.
Thank you, Dr. Krishna Gopal, for that. And if you can now unshare your screen. First academic speaker today is Dr. Mohit Shah, and he will talk about the current ultrasound criteria for the viable early pregnancy. And you can see screen share coming on. Dr. Mohit Shah does not need an introduction to most of us. We have seen him in his many avatars. He is everybody's friend, everybody's mentor. Also officially our vice president of the Society of Fetal Medicine. He is equally comfortable with fetal work as with peripheral vascular and musculoskeletal work. A radiologist located in Mumbai, but with a global presence. And I look forward to his talk now. Thank you, Mohit, for being here.
Thank you so much, sir. You make me want you to introduce me every time. Now, thank you. It's indeed a pleasure. Good evening, all. I thank Dr. Asha and Dr. Hasmukh for having me here. And I'm going to talk on the current criteria to say whether the pregnancy is viable. A few statements. First, it's an embryo till 10 weeks. You call it a fetus only after 10 weeks. And age is expressed as a menstrual age or gestational age is always obviously 14 days more than the conceptional age. And the embryonic development that we see on ultrasound is actually synchronous with the embryonic development time schedule of the Carnegie staging system. So we follow the Carnegie staging system when we're actually tracing the fetus or dating it. So the embryo is around 1 to 2 millimeters long when it is first detected on ultrasound, and it increases by length by approximately 1 millimeter per day. So from an ultrasound perspective, when we say fetal viability, we actually want to confirm the presence of an embryo with cardiac activity at that time in examination. So that pregnancy is a viable pregnancy. So obviously my talk is going to be more on when do you say that this is actually doubtfully viable or it is non-viable. So the cardiac activity that we see is often evident when the embryo is 2 millimeters, but at times in 5 to 10%, you can see that only when the embryo reaches 4 millimeters. A brief para about safety in the first trimester. We know that the B mode and M mode have a limited acoustic output, so they are pretty safe. But when it comes to use of Doppler, it releases greater energy output, and therefore there are potential bioeffects, though not very proven. But it is best that you can avoid color Doppler during the first trimester. So the goal of early viable assessment is pretty simple. You first see whether how many sacs you can see, and that is of paramount importance. When you actually, sweeping the uterus is must. Don't stop when you see one sac. Sweep the entire uterus to find the number of G sacs. If you see a sac, see the appearance of the G sac, see whether you see an yolk sac or an embryo within it, calculate the MSD and CRL, and then assess viability. Of course, your goal is also to rule out ectopic and then confirm or exclude molar pregnancy, but I am not, my buck stops at viability today, and this probably will discuss some other time. The selection of transducer is of paramount importance. We know that the TVS is the most effective way to assess finer details in an early gestation and therefore has to be used in each and every patient. Of course, there are circumstances when TVS would not be possible, like in this case, there was a huge cervical fibroid or a pretty bulky uterus, which is completely straight mid-post, and you see a interstitial pregnancy at the one side of the cornu, and therefore these conditions you can go with a convex probe. There's this paper which shows the 2012 consensus panel, which actually dates the time period as to when the conception occurs and when the GSAC should start appearing. So your GSAC will start appearing between 4 to 5 weeks, the yolk sac between 5 to 5.5 weeks, and the embryo at 6 weeks. So the embryo, if it is at 2 millimeters, you will start seeing the heartbeat. And there's of course a variation of about half week. So this is a sequence of appearance and a timeline that we got to keep in mind. The decidual reaction is the echogenic rim that you see surrounding a GSAC and which actually helps us to differentiate it from a pseudo-gestation sac. But of course, there are no objective criteria and you solely rely on your subjective assessment. But a sac having a thick rim is supposed to be a GSAC. And when you measure the MSD, the protocol has to be very clear. 3 measurements in 2 planes, and then a mean of that is what you actually need to calculate in each and every pregnancy. And the measurements have to be taken from the inner margins to inner margins of the gestational sac. The yolk sac is located outside the amniotic cavity, and it is a determinant of amniosity. So you have to basically confirm the presence of a yolk sac. If you see a sac-like structure, and if you see a yolk sac-like structure within it, that means you are looking at a pregnancy sac, and therefore it helps in confirming an intrauterine pregnancy. Of course, fetal pole has to be measured from crown to rump. And this is extremely important because early scan is a dating scan. So it's how you measure that's going to actually determine the timeline of the entire pregnancy. So measure from the crown to the rump, and you can see the development of the fetus, how exponentially it goes from 6 weeks to 10 weeks. A very important message I want to, sort of give here is avoid clinical terminologies in your ultrasound reports. Terms like missed abortion, blighted ovum, embryonic gestation, inevitable abortion, and threatened abortions are no longer viable use. The only thing that matters is the pregnancy viable or non-viable? So what are the findings that make the pregnancy definitely non-viable? A CRL, which is 7 millimeters and you don't see a heartbeat, a large mean sac diameter of more than 25 millimeters without any embryo, and an absence of embryo with heartbeat when you see a G-sac without a yolk sac after 2 weeks. And when you're following up a G-sac with a yolk sac, you call the patient after 11 weeks, you don't still see the fetus, then it is definitely non-viable. But do remember that whenever the viability is in doubt, always rescan after 1 week. All feti need that benefit of doubt. Having said that, there are a good number of poor prognostic indicators in early pregnancy. When you see an irregular counter of a G-sac, or when you see that it is low-lying and mobile, when you have a large yolk sac, which is defined as more than 7 millimeters, or a very tiny calcified, when you see that the embryo is amorphous shape, severe bradycardia less than 85, then you really, that's a red flag. So you see a small G-sac in relation to the embryo. You see that the sac diameter is extremely small. You can see a CRL there, but this requires a close follow-up. If you have a large yolk sac more than 7 millimeters, again is a poor prognostic indicator. A tiny calcified yolk sac, severe bradycardia, anything less than 85, then you know that this is severe bradycardia, and you follow this up. Mostly this turns non-viable. You don't see the fetal pole, you see 2 cystic structures. That's the classical double BEP sign, which makes it non-viable. Now, when you have a low-lying G-sac, you have to be extremely careful here. First, to determine whether indeed the sac lies within the endometrium, as you can see here. If the sac is indeed in the lower endometrium, then you excluding scar ectopics. And then the other thing is to see whether you see vascularity surrounding it. If you see vascularity surrounding it, then it still could be a low implantation pregnancy. But mostly when you have a non-viable pregnancy, you wouldn't appreciate the vascularity surrounding the sac. And that's what determines that this is indeed a sac in the process of expulsion and a non-viable sac. Sometimes, as you can see like this, it's a very classical, irregular, elongated sac with a large yolk sac in the process of expulsion. The clinical term here would be inevitable abortion, but this is not again an ultrasound term. So keep remembering that this indeed is a clinical term and should not be used in routine ultrasound practice. We often see scenarios where we have a live pregnancy, but the MSD does appear quite small, and these feti mostly don't do well. And this is a very classical example seen with a live fetus. You can see the heartbeats there, followed up after a week. completely non-viable. So if you have a mismatch disparity between the MSD and CRL, do follow these patients. If you have a large GSAC, which is more than 25, it is non-viable with irregular margins. And you see in internal septae, that again determines that this sac is not going to do well. Irregularity is classical of a non-viability and a fetal pole without activity. If you see a mobile sac, now this is very important. The sac appears irregular, but when you have implanted, when a sac gets implantation, the implanted sac does not move with endometrial peristalsis. But however, if the implantation is lost and in the process of expulsion, it will start moving towards the cervix with endometrial peristalsis. Of course, this isn't complete without mentioning multiple gestations. So if you have a large GSAC which is empty in a dichorionic twin gestation with a live fetus in one, then we know that this other sac is a non-viable sac, and that can actually go down in size and dwindle, as we call it, dwindling sac. Sometimes we see this chorionic bump. Now, this is supposed to represent a small hematoma at the choriodecidual surface, and literature says that we need to follow this up because it can have an adverse effect on the developing embryo. But that is a very classical echogenic thing that actually indents into the amniotic cavity. So my point here is that never do an early scan on a transabdominal route, simply because you won't appreciate the structures which are tiny in the intrauterine sac. Follow guidelines to avoid misdiagnosing a viable versus non-viable, and refrain from using other terminologies. Whenever in doubt, please wait for a week and rescan, because every fetus needs that benefit of doubt, all the more with IVF patients, because those are really, really sensitive as well as precious. And do remember that every pregnancy is crucial. So if you have a subordinate with you, make sure that all scans are performed with competent people. If you still have a doubt, if you feel that this could be non-viable, take an opinion from a colleague. This is what we do in my center. If we see a non-viable sac, we always have a second look so as that we authenticate it with two people, and therefore we are more sure that this to say that this is non-viable gestation. And always give the benefit of doubt to the fetus. Whenever in doubt, do follow up after 1 week. Thank you so much.
Thank you. Thank you, Mohit, for that very crisp message. The aim of this whole series of the basic theme of essentials of clinical field medicine is to make sure that we cut out the riffraff and we give you the message directly and clearly. We were wondering whether it was actually correct for us to repeat topics, for instance, and we realized that it's completely sensible to repeat topics because that is the way we get our point home most of the time. But the way in which we will be conveying this message is completely different. And therefore, we have decided that, yes, we will repeat these topics, but in a different perspective. We will take questions at the end, so keep putting them into the chat box, and we will make sure that we answer all of these as we truly go along. So if everyone can see my screen share, am I on? Can the team, anyone on the team, let me know if they're getting my screen
Yes,
share?
sir. Yes, sir.
Yes, sir.
Yes, sir.
Yes, sir, we are
Marvelous.
getting it. Yes, sir.
Excellent. So over the next 25 minutes, I will take you through the current protocols for aneuploidies evaluation at 11 to 14 weeks. And the first thing to realize is that it's not current protocol, but protocols, which means there is more than one. We will discuss this in a formal way initially, and then take you over through the case discussions to keep it informal and get the messages home. So essentially, we will do some basics and then move on to a little bit more. Now, we know that when we talk about chromosomal abnormalities, the most biggest group that identifies with ultrasound genetic screening is the ones where there is an abnormality of the total number of chromosomes. And those are called the aneuploidies. The other group is where you have an abnormality of the structure of the chromosome, and that could be translocations where something goes from one chromosome to the other, or bits that get broken, or bits that change position on the same chromosome, or things that get inserted, and so on. And those are abnormalities of structure, and that's not the same thing as ultrasound genetic screening. What we're going to be talking about today is aneuploidies, which is abnormalities of number. And they're not rare. They're about 1 in 200 live births. And in the antenatal group, these are much higher. But we don't see as many at birth because some of them end up in miscarriages. Some of them end up with a intrauterine fetal demise or a fresh stillbirth. And some, of course, will have neonatal death. The important thing is that there is one group, the trisomy 21, that is associated with mental disabilities. And that's why we chase them, because the quality of life issues are there. And then, of course, with monosomy X, we have infertility issues. But essentially, what we discuss with today is trisomy 21, which is an extra chromosome 21, trisomy 18, which is an extra chromosome 18, and trisomy 13, also known as Patau, which is an extra chromosome number 13. And we will talk about these and mainly about trisomy 21. Why are we talking mainly about trisomy 21? Well, trisomy 13 and 18 are uniformly lethal and do not therefore have very long-term consequences because survival is brief. And so the grief is brief in terms of the quality of life. Of course, to lose a child is as bad as losing anything. The main thing is that almost all of these 13 and 18 trisomies have major structural abnormalities, and these can therefore be identified, and therefore you have almost like a straightforward suspicion for trisomy 13 and 18 on an ultrasound scan between 11 and 14 weeks. And so you have support, and you have some very classical features. On the other hand, for trisomy 21, both the ultrasound findings as well as laboratory findings are subtle. Also, they're non-specific, and therefore we have to make an effort to identify these and analyze their importance. And the other thing is that we need to have a combination of ultrasound and biochemistry, and we will discuss those now as we go along. Now, why is trisomy 21 so important? It's because it's the commonest congenital cause of mental disabilities, and we'd like to know about it. There is the incidence, which is fairly high, 1 in 800 to 1 in 1,000 births, and that is large enough. It leads to considerable ill health, although some individuals may have only a mild problem and can lead relatively normal lives. The problem is that if they don't have abilities and they live a long lifespan, which is what they have in trisomy 21, then they need lifelong family support, and that is very difficult to visualize in any culture. So having a baby with Down syndrome is likely to have a significant impact on family life. Also, there's no currently known cure. So therefore, what happens? A significant number of parents would actually opt for terminating such a pregnancy if their personal beliefs and those of the government or religious faiths allow them. On the other hand, there would be some who would never think of terminating a pregnancy, but at least they could prepare for the kind of life that they have to lead ahead, and that is equally important. Remember that not everyone will terminate a Down syndrome pregnancy. The good news is that we have that option to give to our patients in pregnancy and relatively early in pregnancy, and we can diagnose this condition in pregnancy. There is something called diagnostic test, which is where we obtain tissue from either the developing placenta or from amniotic fluid. And then we have actually the possibility of giving a correct diagnosis. However, these diagnostic tests, which require invasive procedure, are expensive. Also, you do have an inherent miscarriage rate, which is small. We'll discuss that later. And therefore, we wonder whether we should use them for everyone. Therefore, we've come up with screening tests, which identify a large number of patients who would benefit from the next step, which is diagnostic testing. And therefore, the risks would go down and the costs go down. Screening tests, by definition, cannot identify all affected pregnancies. And this is the first piece of advice that you and me should know, and the first piece of advice that we give during counseling in the pre-pregnant patient as well as during each sitting of pregnancy. The other thing is that first trimester screening is by far more effective than later screening, and therefore we have to try and catch them at the right window during the pregnancy and encourage patients to come in for a diagnosis and evaluation of pregnancy as early in the pregnancy as possible. Since screening tests cannot identify all pregnancies and since they're not diagnostic, remember, it is not correct on the basis of a screening test to terminate a pregnancy just because of the hassles involved in terms of giving a final diagnosis. The history is long. This condition was first defined many years ago, 1862, and then again in 1887 by the same person, John Langdon Down, and he told us first that the face is flat and broad and the features have no prominence and the nose is depressed and the skin is very loose. And we still use exactly these features. He used a very politically incorrect term called idiots, but it wasn't such a badly used term those days. But now we don't use words like that. We use words like mentally challenged or differently abled. It took a while for people to realize that this condition was actually a genetic condition. And that piece of information came to us from Jeremy Leon in 1959, years after the first description of the phenotype. We realize it has a genotype, which is trisomy 21 or 3 chromosome number 21. From our screening point of view, our first lessons learned were from the neural tube defect screening, where instead of a high MSAFP as we find in a neural tube defect, it was found that a low maternal serum alpha-fetoprotein combined with a thick nuchal fold in the second trimester scan helped in the assessment of individuals that later turned out to be Down syndrome. And that's where the discovery began. The first ultrasound description came from Beryl Benacerraf in the US in 1987, and Kypros Nikolaides in 1992 first gave us this image. We won't be proud of this image today. I mean, this was truly the first trimester image where they said there is nuchal edema. There is nuchal edema, but that's not how we do it today. Today it's done in a fixed manner, and we will discuss that. And once it was known that there were these ultrasound features, biochemistry was then modified. The biochemistry we had before this was the triple test, which is alpha-fetoprotein, free estriol, as well as beta-HCG. And it was far better than age alone, which would identify only 30%. The triple test was giving us something like 60%. The quadruple test came in the 90s, gave us 80%. And as you can see, new tests kept coming because they gave us a greater detection rate. The combined first trimester screening using ultrasound plus biochemistry gave us like a 80 to 90% detection rate, and cell-free DNA in 2011 gave us a greater than 99%. And therefore, we thought that, okay, the story is over. Ultrasound and biochemistry are out, and we will now just send off everybody at 10 weeks for NIPT, and we have our answer. But it didn't work like that. What we did realize was that in order to have a reliable NIPT report, you need a decent fetal fraction. Fetal fraction refers to the circulating fetal DNA in the mother's circulation that is not of maternal origin, but of placental origin. And if that's not high enough, and we use cutoffs like about 4%, sometimes 8%, which gives us greater detection rates, then we realize that yes, only then we're giving the right answers. And what does this fetal fraction depend upon? It depends on maternal habitus. The higher the BMI, the lesser the fetal fraction. The duration of pregnancy, the amount increases with the passing number of weeks. It depends on the number of fetuses and whether the fetus is alive or not. So in order to know the duration of pregnancy, the number of fetuses and whether the fetus is alive or not, we would anyway require an ultrasound scan. And hence the 11 to 14 week window started coming back again because we realized NIPT by itself is useless. We had to date the pregnancy. And of course, if we were doing that, then we may as well also screen for our aneuploidies, assess and screen for preeclampsia growth restriction, and then of course look at structural defects, which is now what the 11 to 14 weeks scan consists of. And therefore it is here to stay. The question also came that if we were to just use NIPT and disregard the nuchal translucency completely, what would happen? And we had an excellent publication at the end of last year in the journal Prenatal Diagnosis, which told us that if the NT is between the 95th and the 99th centile, not what we use as a cutoff, not 99th, we will still find 21% of fetuses with Down syndrome. And also that if we had an NT greater than the 99th centile, there would be other situations that we would pick up that may not be picked up by the NIPT. Also, that NIPT may not, in fact, give us all the answers, because sometimes you have a no-call rate. A failed NIPT, very smartly, is not called a failed NIPT, it's called a no-call, which is politically something very smart, marketing-wise something very smart. But the fact is, it's not the last word. And if you look at the details from this article, we realize that single gene disorders were picked up in 2% with a 99 centile NT. In 2%, there were some microscopic abnormalities. 30% had chromosomal abnormalities and structural abnormalities in about 9%. If we went on and actually analyzed these cases further. So there's no question then that it is something that is here to stay. What also happened at the same time is that we did realize that although we kept saying that amniocentesis and CVS have a high miscarriage rate of about 1 in 200, then 400 and so on, we did realize that in an expert hand, which means somebody who's doing more than 50 to 100 cases a year and has been doing them for a year or two, then they're equally safe. That CVS is as safe as amniocentesis. Also, that the miscarriage rate is only equal to the spontaneous miscarriage rate, and that the procedure-related miscarriage is not higher than the spontaneous miscarriage rate. And therefore, we suddenly realize, wow. So that means every patient should be offered diagnostic invasive testing. And if they opt out of that, we should then offer them other tests, which is what we will discuss today. But remember that the first thing on our menu is diagnostic invasive testing, because that's useful. Now, therefore, we will discuss now about the current state of aneuploidies detection. We know it's first trimester better than second trimester. And if we were to take maternal age alone, we're looking at a 30% detection rate, not acceptable. If we take maternal age plus nuchal translucency, a well-done nuchal translucency, we're lucky. We get about 80% detection rate. If we take only biochemistry, we fail, because we know that we have to have at least a 75% detection rate for a test to be put into practice. These are ISPD guidelines, and just biochemistry does not match those. So we will not use maternal age and biochemistry alone, irrespective of how good it might be. If we combine maternal age plus nuchal translucency plus free beta HCG and PAP-A, which is called the combined test, it gives us an 85 to 95% detection rate with a 5% false positive rate, which is the best acceptable test for the population today. If we find that we have a problem, then you could add on ultrasound parameters, or you could add those on in your regular program, depending on whether you're working with large number of patients and have pressure of patients or not. And then your detection rate not only goes up to 96%, but your false positive rate falls down to between 2.5 and 3%. And therefore, more and more people are now including the additional ultrasound parameters to make sure that the protocol gives you a better detection rate and a less false positive rate, which means less number of invasive procedures. So it's taking us to where we want to reach. Second trimester screen, whether we use a triple or a quadruple, we'll never use a triple because we realize it's below the 75% mark. Quadruple acceptable, but more for people who missed their first trimester or people who didn't want an invasive testing in the first trimester. But if we do a sequential screening, what is now called an integrated one, depending on whether you give out the results of the first lot, these days everybody gives out the results of the first lot, then we have a pretty good detection rate of about 90 to 94. But remember that you must include the NT sitting right there, otherwise your detection rate falls. So first trimester better than second trimester, standard procedure, maternal age, nuchal translucency, free beta HCG and PAP-A, and if you add on the additional parameters in ultrasound, much better detection rate. Now, the few things that you must know about, one is that all these findings of a thick nuchal translucency, an absent nasal bone and so on, a low PAP-A, a high beta HCG can be found in normal fetuses as well. And therefore, these are called markers. They're not called diagnostic signs. In normal findings, in normal fetuses, if you have these findings and the karyotype is normal, we are very happy. And therefore, then we don't have to worry, except for the thick NT, which needs further follow-up. But otherwise, we don't get worried about them. Now, When we put all this together, we assess the risk, and then depending on the cutoffs we use, we decide what the patient should be guided for. The important thing to realize is that some people like to use a mathematical cutoff and some do not, and we will discuss that as we go along. Again, to remind you that ultrasound and biochemistry are screening tests, and therefore they should be offered to everyone, and diagnostic testing would be for those who test positive, and that is the test that will give us a final diagnosis. Of course, some patients will opt straight for diagnostic testing, and that's a perfectly viable option. Now, when we put all this together, we combine the crown rump length with the NT, with PAPE, free beta HCG, and maternal age in the background of maternal weight, ethnicity, IVF or not, number of fetuses, diabetes mellitus, and smoking, and get our answer. And remember that the additional ultrasound parameters enhance detection rates. And these, like I told you before, are the nasal bone, the ductus venosus, and tricuspid regurgitation. There are parameters that have come and gone, like the facial angle, which is not sensitive enough, so we don't use it anymore. And the hepatic artery, which is more difficult to get, but performs just like the ductus venosus. And therefore, why should we do something that is more difficult to get? Now, remember that each of these is a well-defined parameter, and it has to be done in an ultrasound correct method to do it. First of all, of course, that the fetus has to be between 11 weeks to 13 weeks, 6 days, which is 45 to 84. Some people might say, but 45 is actually 11 weeks and a few days. Well, we go by 5th and 95th centiles, and therefore we use this wide gap of 45 to 84. The next thing is that whenever we do these, we must have our nice fixed criteria sitting there of a true sagittal section, the fetus in a neutral position, which means that there should be fluid between the chin and the chest. It shouldn't be applied too closely, otherwise the back of the neck might get thicker or narrower. And the fetus should occupy as much of the screen as possible. And you can do this either by a pre or a post freeze zooming in. And then remember that for the nuchal translucency also, we have very well defined things, which is the same fetus, same position, but we include only the head and the upper thorax. And we distinguish at the back of the neck between the cord, for instance, the amnion and fetal skin, and again, fluid over here in a true mid-sag section, which means the zygoma should not show up between the nose and the palate. Remember that we will always see here the tip of the nose, the skin of the nose, and the nasal bone as 3 separate structures. We will see the midbrain very clearly. We will see the intracranial translucency sitting there too, the future cisterna magna, and so on. And therefore, this view also offers a lot of additional information. Remember that we have to make sure that the gain is turned down so that these are more sharply marked, and we never use an absolute value. We use a gestational age-related nuchal translucency thickness. To measure that, we must place our markers properly, calipers, and we must make sure that they're on to on, which is edge to edge. The plus marker is to be used, and the horizontal band is to sit on the white portion. So this is a correctly measured NT, and not something that would be further away or less as shown over here in the other markers, in the other marked pictures. Now, once we've done all of that, we must also, in the same image, try and, to the extent possible, look at the nasal bone. To make sure you're seeing it correctly, make sure that the total fetus is as horizontal as possible, because sometimes if you have a very vertical fetus and it's not all in the same plane, you might actually miss out on the nasal bone, and that you must see the nasal bone separate from the skin that is overlying above. Then it will be reliable. And remember that again, you can see it in normal fetuses, but more importantly, you see it in about 70% of trisomy 21, 50% of trisomy 18, and 30% of trisomy 13 fetuses. So that's how we go about this whole story. The ductus venosus, again, you need zooming. You need to have a sweep speed that you don't have overcrowding, and that we use not the reversal of flow, but the actual PI, which is at the end of the cardiac cycle, we see the height of the A wave, measure it out, and then we get a PI of the vein, and that is what we use, not the fact that this should be here. It takes skill and time, but it's an independent marker from nuchal translucency and useful to use as an additional marker. Tricuspid regurgitation, easy to get, but again, follow the criteria and make sure that it fulfills the criteria. Otherwise, you're not doing a good job. And sweep speed is important, not a crowding of sweeps like this, but waveforms nicely seen so that you can calculate them nicely. Some gross, some subtle, but they all must exceed 60 centimeters a second, that we must have an apical 4-chamber view, a gauge size of 3 to 4 millimeters. The regurgitation must occupy at least half of systole, and then you move on. And that's the way to do it. Remember, ISPD recommendation, anything below 75%, not acceptable as a test. So what models do we have? We have age, which we don't use because it identifies only 30%. CRL and NIPT is very good for the first trimester, but it misses the advantages of screening for anomalies and screening for preeclampsia, very important. Also that even though it's become cheaper now, it's still very expensive and therefore is not the first option. If you use age, crown rump length, and NT, it requires skill, but otherwise is good. Age plus biochemistry has a poor detection rate, but the best test remains age plus crown rump length plus maternal factors plus NT plus PAP-A plus HCG. If you add on additional ultrasound markers, great, you'll get better results. You could try a combination of the first and second trimester quadruple, but there are two new options. One is that in the first trimester, you add on not only the PLGF, which we use for preeclampsia, but alpha-fetoprotein as well, so that you get additional sensitivity as well as the risk for neural tube defects. And the relatively newer Penta test, which has also added one more variable, which is the dimeric inhibin A. And this increases the detection rate to above 98% with a false positive rate of only 1%. So this seems to be one possibility in the future. But if the price of NIPT comes down, then we won't need the Penta anymore. So this is the protocol that we have available, and this is how we choose it. And we will conclude at the end and remind you about this. Now, once we have all of that, typically if you have risks of 1 in 10 or more, that is 1 in 5 or 1 in 6, you offer invasive testing more emphatically. Counseling for testing should always be non-directive, but that's never possible in a human setting. And therefore we start thinking. If you have a low risk, which is that the risk is less than 1 in 1,000, like 1 in 1,050 or 1 in 2,000 or 1 in 10 or 20,000, then all you do is a routine second trimester scan with a second trimester genetic sonogram, and you're doing all right. If you have an intermediate risk of between 1 in 50 and 1 in 999, then there are some options. One is additional ultrasound features, or offer them NIPT, and this is what is being suggested by the Fetal Medicine Foundation these days. And if you're sitting somewhere between that 1 in 10 and 1 in 50, then let the patient choose between NIPT and invasive testing. Remember that not everybody uses guidelines, that these are not sharp cutoffs. Let the patient make the final decision, and you have to lay this on like a menu in a cafeteria. And some people like to use cutoffs of 250, some people like to use cutoffs that are different. It doesn't matter, but remember that this group is important. Between the high and the low risk is this risk of the intermediate, and they must be looked after because there's a very significant number of aneuploidies in that group, and that's where we like to be careful. When we add on the NIPT to the intermediate ones, it's either positive or negative. If it's negative, you're very happy and nothing else needs to be done. They go back into the routine low risk. And if it's positive, then of course you move straight to invasive testing. Remember that all of this needs to be always integrated with what is already available and what is in the future. And therefore, your knowledge is extremely important to make sure that, yes, this is the way it truly has to be done. Now, there are some anomalies that override in this entire thing. And then you move straight to invasive testing. And one of these is that if you find a thick nuchal translucency or an omphalocele or a megacystis or an atrioventricular septal defect, a tetralogy of Fallot and some of the other cardiac abnormalities, or a cerebral ventriculomegaly, then you start straight away thinking in terms of invasive testing, and you start wondering whether you should just stop there and then not do any more screening unless the patient says, no, I would like to wait and make up my mind. Then you offer them other things. And remember to remind them that NIPT is only for trisomy 21 as we understand it today. In the future, it has a lot of promise, I admit. But as of today, it's a great high efficiency screening test for trisomy 21. And remember that decisions are to be taken by the mother, the couple, the family, and in our particular situation, the entire neighborhood. And therefore, we need to counsel just about everyone, and we have to be patient about that. Remember also that if you have an abnormal biochemistry, it's not just an indication of a biochemistry, but possibly a bad placenta. So if your PAPI is less than 0.4 particularly, follow these up more closely in the third trimester for growth and preeclampsia. Remember that we must always combine these with the other advantages. Therefore, there's no question of doing without a first trimester scan between 11 and 14 weeks. Now, also that if you have a thick NT, you have to think beyond chromosomal abnormalities, so the chase doesn't stop at getting a good karyotype or a normal chromosomal microarray. You have to then look for other things as well. Now, the nuchal translucency, the thicker it gets, the more the chances of aneuploidies and also the chances of other fetal abnormalities. So like I said, always keep an open mind, and the story doesn't end until you get all the way to a fetal echo, by which time you've done your anomaly scan, and then therefore you're quite comfortable that, okay, there will not be too much of a hassle. Remember that size does matter, and for anatomy, we don't like 45 millimeter fetuses, we like at least 63, 64 millimeters. Therefore, an ideal time for an anomaly scan is about 12 weeks. Some of the PAPI, which is abnormal, low PAPI, is not so low by 12 weeks. But if you want to make it convenient for the patient, it's a good idea to actually do all of it at one go at about 12 weeks. However, ideally speaking, we should do a biochemistry at 10 weeks and an ultrasound scan at 12 weeks plus. Now, number of fetuses, yes, with twins, we can still do this. And I'm not discussing this in detail today because we will have a separate session on this. And I want to spend 2 minutes on my remaining slides. And that is that, to conclude, in the economically privileged patient, first trimester screening should include an 11 to 14 weeks complete assessment, plus a first trimester combined screen with PLGF to assess for preeclampsia and placental function, and an NIPT in the economically privileged patient. For population screening, which means in health systems where government pays for it or insurance pays for it, we probably can only offer the best as a combined screen, which is a good method. And that is maternal factors plus NT plus PAPI and free beta HCG, all quality controlled. If you feel that you are overloaded or you don't have equipment, or that you don't have a good personnel, then the institution must define this and tell the patient that, look, you can get it done if you wish to, but we don't have the facilities, or we can only do NT and we can't do the biochemistry, or the fact that, look, we're just not reliable, but you can just do it whichever way you want. We must identify by every institution in writing that this is our institutional protocol, and it's completely acceptable. After all, we have a varied population. But the fact is that we must offer it to everyone, and it's up to them to then take it. Remember that in this whole story, the finding of a thick nuchal translucency or a structural anomaly must be fast-tracked invasive testing, that the invasive testing should always include a FISH or a QFPCR for rapid diagnosis, which is like within 1 or 2 days, or maybe 3 days, and a microarray, which is the basic assessment now, rather than a karyotype, because you pick up 6 to 9% more. That NIPT without an 11 to 14 week scan misses a large number of significant abnormalities, some of which can be lethal or major in decision making. And that if you have a patient who's already going to get invasive testing done, don't forget that the best way is to always include a QFPCR for trisomy 21 so that you don't miss this. So if you have someone undergoing a CVS for thalassemia, for instance, then a QFPCR must be included for your aneuploidies analysis. And also to remind you that the story of ultrasound and genetic technology for assessing the fetus has only just begun, and we look forward to a very exciting future. Thank you so much. We will take questions at the end, and I will stop sharing my screen now and move on to the second part. We will take a minute to show off, if I may say, our trade partner videos. We'd like to let you know that trade partners are doing this for us, and then I will hand over the floor to our panelists soon after the trade partner videos. And so we are back to pure academics again. It's time for a panel discussion. I promise you we have left plenty of time at the end for audience questions. And we have received some very interesting questions, some of which will be answered during the panel. And I now invite Dr. Chinmay Rath to take over the panel discussion. Chinmay Rath is from Hyderabad, but we know that truly she is what I call son of the soil from Odisha, and is one of our finest teachers that we've known. She's been on the executive of the Society of Fetal Medicine since its inception. And I look forward to her questions. Answering these questions, we have Dr. T.L.M. Praveen, who is a president of the Society of Hyderabad with several firsts to his credit. Then we have Dr. Ratnapuri, the biggest name in genetics that we have today. Also, the most accessible person. And you know that she is one of the most fantastic persons to help you out whenever you're in a spot. Dr. Bimal Sani, our president-elect of the Society of Fetal Medicine. He has a practice in Aurangabad and is one of the most revered teachers, and youngsters feel very comfortable with him to ask all their questions. Dr. Aparna Sharma, who is our Joint Secretary at the Center for the Society of Fetal Medicine and is at the All India Institute of Medical Sciences, New Delhi. I look forward to a truly vibrant discussion, and this will be followed by questions which will be coordinated by Dr. Hasmukh Lal.
Thank you, sir. Thank you very much. And indeed, it's always a privilege to be part of the academic program of the Society for Fetal Medicine. And like sir said, we'll be doing things a little differently in this exercise with the Chhattisgarh Society. And the difference is that, you normally have questions first and then you have answers. This is a session where you've already had the answers given out to you. The talk that Professor Khurana took for the last 25 minutes gave out all the answers for whatever we're going to be discussing in this panel discussion. And our experts will only rephrase those answers for the sake of that information going in clearly and indelibly into everybody's mind, because there are so many questions in the chat box. Every time we have similar questions, it's a different batch of people attending every time. But screening is a concept, and once you understand that concept, things will never go wrong. This is first trimester aneuploidy detection, case-based discussion, because whatever you learn in theory, your final test is applying it on a particular case. So what we have learned so far is aneuploidies are abnormalities in number of chromosomes. You've heard that in the talk right now. Screening is a process which you do a test on low-risk population to pick up high-risk population. But finally, detection is by doing an invasive test and looking at the chromosome and detecting an extra chromosome or a less chromosome or any kind of aneuploidy out there. So here we are, where we want to do the best by our patients. And just now, Dr. Khurana has told us that the first trimester combined screening test makes a lot of sense. You do the double marker test and you do an NT scan within that 11 to 14 weeks period. And then whatever you get as a result of the risk for that fetus for Down syndrome gives you a sensitivity of close to 95% for a very low false positive rate of about 3 to 5%. So this is the first case where we have a 25-year-old primee gravida. She's pregnant for the first time, and she has come at 12 weeks of pregnancy. The fetus has a crown rump length of 56 millimeter, and the NT is 4.7. Dr. Khurana just told us that you cannot use NT as a standalone factor. It has to be weighted against the gestation. Gestation is 12 weeks, CRL is 56, but her NT is increased because it's 4.7 millimeter. Now, this looks like a high risk for trisomy 21 on scan. With this report, she just comes and she's panicking all over. Dr. Praveen, what should we do now? I mean, increased NT, high risk for Down syndrome. How do we proceed from here now?
Yeah. Thank you, Chinmay, for giving me this question. See, basically what we have is NT being 4.7, obviously is definitely, okay. Sorry, 1 second. Obviously, it indicates that, sorry, 1 second, I don't know what's this. Basically, we know that it is definitely more than 95th centile or 99th centile as such. So when we have a high NT of this sort, which obviously says that there is a high risk for T21 on scan, we have to make sure whether the crown rump length, because most of these ultrasound markers are gestational age based. So when we have a gestational age-based marker, we need to ascertain the gestational age based on the crown rump length. So proper measuring of the crown rump length is essential. Re-evaluation or reconfirmation of the nuchal translucency is extremely important. Now with this, because if it is high risk of with the increased NT, first and foremost thing, there are two options that we have. One is directly go and evaluate the other structural abnormalities, which also could be based like cardiac abnormalities, which are one of the most commonest things when we find that there is an increased NT, or subject them to an invasive testing so that we can categorize them, and then we can find out whether it is the. So basically, we need to either do a thorough evaluation, structural evaluation for major defects, and then proceed based on the evaluation which we have confirmed. So we need to confirm the NT, we need to confirm the CRL, we need to evaluate the structural abnormalities of the fetus. This is what I feel.
So we did all that, and it looks like the CRL was appropriately taken, the NT was appropriately taken, and it's definitely high. And now you're saying that there could be an aneuploidy, there could be a genetic syndrome, there could be infection, there could be structural defects. Why to go ahead with this pregnancy, sir? Why can't we just terminate this pregnancy and move on?
I think that's not an answer for it, because we need to further evaluate them, because this is not just because it has to, I mean, we have not yet evaluated for the structural defects, isn't it?
So
Hello?
you want to evaluate, I mean, even if the mother is panicking and she's saying that there are so many problems in here, it's a 4.7 NT, that graph which we saw, it's way beyond that. But why are we then pulling on?
I mean, because see, it's just the increased NT is not, it's only a screening. We are not confirming anything.
And you think somewhere it could also be a normal variant?
Normal.
Yes, yes, yes. That is the reason why we need to further evaluate her.
And I think everyone is hearing this loud and clear, because when there is an increased NT, however increased it may be, whatever graphs, you see, we've shown you these scary graphs of what all can happen if the NT is increased, but everything is a percentage. And if everything is a percentage, there is still a percentage of people who are in that 4 to 5 range, where you may still have a healthy live birth despite having an NT that large, after you have ruled out everything else. So if you encounter increased NT, you have to go step by step. Like sir said, you have to screen for everything else. You have to diagnose whatever you can diagnose, but there could still be a normal outcome, and therefore you don't terminate with increased NT, but move on. Now, Dr. Bimal Sani, we want to move on. Is there a role of doing biochemistry in this case, or should we directly proceed for an invasive test? It's 4.7 NT. Do you want to do the biochemistry? Because the first trimester combined screening test is very good.
No, with such a high NT, and you have already pointed out that it is not just about aneuploidies. There's so many other things that could be associated with that. And we know for sure with the 4.7, I would definitely want to go for a definitive testing. That's for sure. So I would probably avoid a biochemistry, because I would save that much of money for the patient. So my options were what? Biochemistry, NIPT, and invasive testing. So I would ideally go for an invasive testing with DNA storage also. Maybe karyotype or microarray, rule out the basic stuff, but with DNA storage, because maybe at this stage I may not be able to pick up the structural defects, but later on, if suppose this turns out to be karyotypically normal, and then at 16, 17 weeks, we pick up certain other anomalies which could go probably towards a genetic syndrome, then the DNA would be important. So there's no point wasting.
So I think, yes, sir. So I think what you want to say is, anyway, you have to do an invasive. So you would probably not do the biochemistry here, because you're saving money for the patient. So I think we can go back to Dr. Khurana's slide, where he said for the economically privileged patient, you may do certain things differently. So because the role of biochemistry is also about placental biomarkers. So if the patient doesn't mind the cost, you can do that, having understood that this is not going to alter her risks for the aneuploidy as such. And if you have a protocol, see, some places there is a protocol of doing a combined screening test as such. So we need not segregate there now that we will not do the biochemistry here. We can continue doing it if the patient doesn't mind the cost, which you pointed out is the most important factor. And that will give us information regarding preeclampsia and things like that. But for aneuploidy, definitely you're going to go ahead and do an invasive test. And in the invasive test, you don't want to stop at only the karyotype. You at least will do a microarray if possible, and keep the DNA if for other genetic syndromes also later on.
Yeah.
Okay, thank you, sir. Now we move to the other question. Dr. Ratnapuri, madam, does NIPT help in this situation? We now have a very fancy test.
Yeah. So really no, because NIPT is also a screening test. So we are jumping from one screening test into another screening test. And of the 23 pairs of chromosomes, it only checks for 5, 13, 18, 21, and the sex chromosomal abnormalities. And if somebody says that, well, I can even check for microdeletions and I can look at all the chromosomes. But remember, we have a very, very high false positive rate there. And it's not very sensitive for looking at the whole genome or looking at all the other chromosomes and microdeletions. So NIPT is not a good option. So like you said, you have an increased NT. You could or should do the preeclampsia markers. There you don't need to do the full penta test. You would just do, or the combined first trimester screen, you would just do the PIGF and the PAPA. That is also a little difference in the cost. And then an invasive test looking at the all the chromosomes. Microarray is important. I wouldn't stop at a karyotype. And when you do a microarray, DNA is automatically stored.
So Down syndrome has been like overstated in this aneuploidy screening program. And when we talk of increased NT, we are talking of things much beyond Down syndrome as well. So if you do an NIPT, probably you'd rule out something like Down syndrome to an extent of 99%, but that's not enough. And therefore, we don't do NIPT in cases where there is a structural defect or an increased nuchal translucency in the first trimester. Thank you, madam. So, Dr. Aparna, after having heard everything in this case, would you just want to summarize the take-home messages for a condition where there is increased NT in the first trimester?
Yeah, so good evening, everybody, and thank you for this question. And I think my job is really easy after such lucid answers from everybody. But I would like to really summarize by saying that, yes, first of all, please look at the pictures when they say that NT is increased. Just yesterday, I got a report of increased NT reporting it is 1.1 centimeters, while the image actually was 0.1. So please look at the images before you actually start doing something for increased NT. So that is number one. And also, as sir said, please look at the CRL and do a centile charting. If it has not been reported, you can always look up the internet yourself and do a centile charting. There is a lot of difference between more than 95th centile and more than 99th centile. So as a rule of thumb, anything which is more than 3.5 is really abnormal. So you can actually say that, okay, the chances of other abnormalities are more, kind of probable. So yes, and once NT is abnormal, it is more of a structural marker, as has been said. So let's not just stick to NIPT. And one interesting question that you put forward, and I thought it was really interesting, that why not terminate this pregnancy? Why even go for this? And we actually get patients like that, NT is abnormal, I want to terminate this pregnancy. Now I have two answers for that. So number one is that, like you showed the chart, even if NT is 4, you have a 70% chance of having a normal baby. Would you let go of that chance? And the second thing is, if you do not investigate this time, what is the chance of a recurrence? How would you know? So these are two things that we need to keep in mind when we counsel these patients, and let's not go for abortion at the drop of the hat. So on the other hand, we do have patients where everything is normal, but they say that we still have a residual risk of 1%. So we still want to terminate. So we've had that end of a spectrum as well. So when we think about an increased entry, we need to think about the whole spectrum, but let's not terminate without explicitly investigating the case.
Absolutely, absolutely, I agree. And the only way to avoid any risk for aneuploidy is not to have a pregnancy at all, isn't it? The only answer then is contraception permanently. But if
To
you have
avoid
to,
any risk, aneuploidy is something which is very easy to identify.
so this whole concept of risk, sometimes it takes us off balance, especially when we are handling these cases in new in our career. We really get very, very carried away with a lot of problems and things. But if you approach it correctly and cohesively, the way we have seen in this case, you can take it forward. So increased NT opens the door for a lot of investigations. Yes, there can be alarming moments in those investigations, but this is not a reason for you to take the shortcut and terminate the pregnancy.
Most of the times with, sorry.
Yes, sir.
Most of the times when you have such high NTs reported, as Aparna said, quite a few times they would probably have measured it from the amnion to that. So,
So that
you
is
know,
also another thing, like you very rightly said, whenever we are giving an NT report, we should give an image of that NT with the report. I think that's imperative on the part of the sonographer. And once that is done, it gives an opportunity for the other person also to evaluate whether it's been done. Because that 1.1 centimeter could be a very small, sprinting mistake sometimes.
Reported as 10 mm, while it was actually 0.1. So it was 1.
Yeah.
So that was
these things will happen. So please remember that, check the CRL correctly, check that the NT is correct, and only after all this, take the steps as have been described and move on. Now we have a second case scenario. She is a 12 weeks primigravida, 56 CRL, NT is 1.6. This is well within normal limits, and we are very excited about this pregnancy because nothing is wrong. Now she goes for the combined test and comes back with a high risk for trisomy 21. And that has happened because her beta HCG moms is 1.9 and PAPA mom is 0.2. So again, she's landed up in high risk. You had a very normal NT. You told people how to do it correctly, measure it correctly, report it correctly. Everything perfect. But again, high risk for trisomy 21. Bimal sir, she's come to us now. What will you do?
now in this case, it's the biochemistry which is actually causing it to, it's causing the high risk there. And as you pointed out, actually it's the PAPA which is the one which is really making the difference there. So, before I make it, it's a very, very strong message that I want to tell everyone is that when you get this report, just don't look at screen positive and screen negative. Please look at the moms. It's a very, very important entity. What is it which is? So, because with such a low PAPA, yes, it could be a placental factor that would be involved. But then because she's come as screen positive in this kind of a case, I would like to go for an NIPT in this. And of course, before that, involve the, do the other markers, include everything.
If it was intermediate risk, you'd go for the other markers. And if it is high risk, you want to go for NIPT. And just now, Ratna ma'am told us that NIPT is not going to be useful. We'll come to her in some time. Patient went and took another opinion. She didn't like your idea. She thought maybe Dr. Aparna will give us a better idea. And she said, Madam, I want to do quadruple test. I don't want to do NIPT.
Quadruple, actually, so there's one very good, I think, adage, or I would say, principle that we should always follow, that we should avoid two biochemistries. That is one thing that I think is very important. But if we are able to, if we want to do biochemistry, are we, trying to integrate these tests? So are we able to do that? Are we, if the first test has been done on a lab where it is validated to integrate the first and the second tests? So that is one thing that we need to remember. So if we have done one test from a different lab, and then we try to integrate quadruple from a different lab, that doesn't really work. So doing a quadruple, as a separate entity, it is kind of, it is going to confuse the results even further. So it is very simple to follow this principle, that in a patient who has come to us, let's not try to do two biochemical.
So what will be your pre-test counseling? She's got the first trimester screening done, beautiful NT 1.6, everything fine. But she did a biochemistry. The day the NT scan was done, doctor said everything looks good. And then the next day when she came to collect her report, he said, no, it's very high risk. So she got really bugged. She came
when you define as high risk, what was the actual risk that you said?
1 in 89.
Yes, so because it is a reasonably high risk, I would say that, see, your risk is 1 in 89. So you can actually try and go for invasive. So we need to offer her invasive, saying that it is high risk. But yes, NIPT is an option. But I would personally say that because your risk is higher, so you can actually go for invasive. I personally will not give her a second
Now
biochemistry.
see what our patients are going through. They went to one doctor who said, oh, beautiful scan, everything is lovely, wonderful, just give this blood test, it's going to improve the sensitivity of screening, come tomorrow and collect your report. Next day when she comes, the same doctor is very gloomy and says that, oh, I'm sorry, now it's very high risk and your baby can have this, your baby can have that. She goes to another doctor who says, oh, I'm not sure another blood test is going to help you, maybe you do an NIPT. Ratna ma'am, last time you told us it's not going to help us. So I still send the patient to you and I'm kind of sure you'll tell us it won't help us. What are you going to tell her now?
In this situation, it's 1 in 8. So, we are just working with figures, and high risk is not equal to the baby having a disease. It still means that 98 to 99% the baby does not have Down syndrome. If we are arguing only about Down syndrome, okay? So in this case, if the NT is normal, the family history is okay, there are no additional malformations, NIPT is not a bad option to offer because we are primarily assessing the risk for Down syndrome, and it is a very good test for Down syndrome. The sensitivity of the test is very high with a very, very low false positive rate. So I could offer NIPT here, of course, with appropriate pre-test counseling about what it looks at, what it does not look at, and if it is high risk, that we would need to do the invasive testing. I think I'm quite okay here.
But why are you thinking differently in this case as opposed to the first case?
Because there is no structural abnormality. The nuchal translucency is normal. And increased nuchal translucency increases the risk of chromosomal abnormalities in that specific NT. It was about 20 to 25%. And I know that about 3 to 4% of those are structural abnormalities of the chromosomes. So that is why the NIPT is not a good option there. Here, it's a normal nuchal translucency. You've only tested for Down syndrome and you're further evaluating the risk for Down syndrome. Even in my counseling, I'm going to tell them, if I do an invasive test, there is a 1 to 2% chance I can pick up structural anomalies and allow them to choose. I would not choose for them. I think that's the first message that we have to give is it's the choice of the patient. I know very often they say, Dr. Saab, aap hamare, if you were in our shoes, what would you do? That sort of a thing. But at the end of the day, I still leave it on the table and I tell them, well, I would do this, but this is your baby and you have to decide. And I think that's the way we have to teach our patients.
Absolutely,
Madam,
ma'am.
I have
And
a question
yes,
for
sir.
Dr. Ratnapuri.
Hanji,
Think of,
yes.
Is there a chance that in such a situation there could be trisomy 16?
I would not worry too much about trisomy 16,
Yeah.
because only mosaic trisomy 16 is viable. And most of trisomy 16 usually ends in a first trimester abortion.
Abortion, yes.
I mean, most of these big trisomies end in abortion.
Right.
Thank you.
No,
So I think, Praveen sir, you want to say something? Yes, sir.
Yeah. Chinmay, when you say that the risk is 1 in 89, I mean, definitely with 1 in 89, I think invasive would have been a better option rather than going in for an intermediate risk, because if it is anything more than 1 in 100, maybe between 1 in 100 and 1 in 999 intermediate risk, then NIPT. Why not add the other markers like the nasal bone, ductus?
No, that Dr. Bimal did. So the patient came, she had the scan, and then when he added all the risks, obviously if it's 1 in 89 without including these markers, and if these markers are normal, it will fall into the intermediate risk. He already said that. But what I'm saying, sir, the patient got confused because first she was told the scan, everything is normal.
No,
thereafter,
the scan will be normal, but then the combined test
biochemistry changed the risk.
Yes,
now she has this doubt whether she she should go for another biochemistry because quadruple test is a bigger test. Double is only 2 markers. Quadruple has 4 markers. So she went and took another opinion because that, and this is exactly what happens in real life because Dr. Bimal Sahni told us in the first place that let's go ahead and do an NIPT. But we didn't listen to him at that time because, you know, sir, unless we take 2-3 opinions, we don't feel satisfied. So we've taken the second opinion and Dr. Aparna said, okay, quadruple is a good test, but we may or may not be able to integrate it. We may or may not be able to do it. And it's like looking at it from a bigger sieve. You've strained a solution with a very tight sleeve and now you take a bigger strainer and try and strain the same solution. You're not going to get better results than the first one because the sensitivity of the quadruple is lesser than the. So she was still not very sure whether we should do the quadruple or not. NIPT, because we ruled out first time, now whether the same geneticist is going to advise us NIPT, yes, that is because the test is not good or bad. It is the indication of the test which has to be considered. NIPT is a great test to rule out Down syndrome to a sensitivity of almost 99%. It has to be just used in the correct indication. So this is a woman who's scared of doing any more tests. She may not want an invasive test right away. Of course, we'll offer her the invasive test as the final detection for aneuploidy. But suppose our screening is failing at a level of biochemistry where the scan is looking perfectly normal, then could we consider NIPT was the question. And madam said, yes, we could consider the NIPT. Now, suppose she doesn't want the NIPT, she wants the invasive test, madam. In this particular condition, would we go ahead and do only karyotype? Or here also you want us to do the microarray?
The only reason not to do a microarray is the cost of the microarray over a karyotype. If I could bring the cost down to that of a karyotype, I would do a microarray all the time because it's a better test. Even if there is no structural abnormality in the fetus, it identifies 1 to 2% of structural chromosomal abnormalities, which would not be picked up by a karyotype. Hence, it's a better test.
That opens up another Pandora's box, ma'am, because this only gets addressed, this issue only gets addressed in the people who get a high risk for Down syndrome for whatever screening tests we have. So that entire group of people who pass through our screening tests as low risk, even they should be theoretically carrying those chromosomal abnormalities.
You know, the thing is that every time we start counseling a family, ideally they should be counseled before even a screening test is done, not NIPT, but even before a first trimester screen is done, because it's passed off like a complete blood count test and they don't understand anything until it comes screen positive. And if it's the second pregnancy, they'll always tell you in the first pregnancy, this test was done and everything was okay and my baby was perfect, because that's the understanding. But remember, everybody starts a pregnancy with a baseline 1 to 2. I say 1 to 2, not to psych people, because nobody would go through a pregnancy otherwise, but there is a baseline 2 to 3% risk of any kind of abnormality that can happen. These could be abnormalities of chromosomes, of fetal structure, or they could be abnormalities of single genes. And we cannot exclude everything. It's like walking on a road. You can't exclude the risk that somebody will come and bang you from the back, you know. So yeah. I also think that the families have to be counseled in a perspective that they actually continue to enjoy their pregnancies. I think pregnancies have become such hellish 9 months because of all that we keep doing and all the shopping that they keep doing. So I saw a question that popped up. Please explain to us stepwise screening. And Chinmay, I think I had to sum it up. So is it okay if I sum it up like this? The case?
One more thing, and I think if this confusion would have not been there, if there is a even pre-test, first trimester screening, where you are starting to do a nuchal translucency, to talk to the patient that nuchal translucency is not the end of the road, that you need to get a combined test and you have to put both together, and that's the reason why we call it as a combined test.
Combined test.
So
I think what you all are pointing out is a good pre-test counseling. Exactly. And what Dr. Ratna is pointing out is the counseling even before the whole process of screening is undertaken. Yes. So that the patient knows exactly what is the limit to which that he or she is being tested, and what is the expected results, and what are the expected results thereafter also, because at any stage we will not be able to say that we have ruled out every possible condition. So I think, Madam, you've already summarized it for us. Just can you give us take-home messages based on this?
So the take-home message is, remember that this is a screening test. It's not a diagnostic test. And you are screening for a common chromosomal abnormality, which occurs in 1 in 1,000 births. And it's not as if we are screening to eliminate Down syndrome from the face of the earth, because sometimes the family already has a child with Down syndrome and they come to you for counseling and they love their child. So we have to be very gentle in our approach to families with special children. And I know we all are busy, but I think we all have to have that little humane thing when we deal with these patients. We have a lot of screening options. And I loved the word that Dr. Khurana uses. It's a cafeteria approach. I always worry, am I doing the right thing? But if I go to a cafeteria and I choose dish B instead of dish A, and somebody else chooses dish A, neither is that person wrong and neither am I wrong. They are just different options. So we have many options that are available. In the first trimester, the good option is the combined first trimester screening, which includes a good NT, the CRL, all the baseline characters, including the correct date of birth and not an official date of birth sometimes we all have for school admissions. So these are important things that need to be checked into, along with the free beta HCG and the PAPE. And this is a good screening test. However, if somebody can afford an NIPT after a good scan and maybe screening for preeclampsia, an NIPT can also work as an option. There is one thing to remember, which Aparna also said previously: no two independent risk estimates. Don't do a first trimester screening and at 16 weeks do a quadruple screening. If you want to do that, please integrate the risk of the first trimester screening into the a priori risk of the second trimester screening. And I feel also important for this case is we've all forgotten about preeclampsia, because essentially the PAPE was low. So if she had come to me in that window, I would have made sure that an appropriate preeclampsia screen test was done and she was not arbitrarily started on Ecosprin, which happens most of the times.
Because the session is only for aneuploidies, I left out the preeclampsia part.
Oh,
but
sorry.
With aneuploidies, the whole approach is that we do adequate pre-test counseling, because this whole like scare about screening tests is because of the way we handle it. If we don't do pre-test counseling, whatever is the result, it comes as a shock to the patient. And once it comes as a shock and the patient goes into a panic mode, we don't think reasonably. And then we keep doing this, going from one doctor to another, suggesting one test over another. And then you don't look at the whole thing in perspective. So please look at it in a sequential manner. Check what was the result of the previous test before you embark on the next test, and do a adequate pre-test counseling, which is going to solve a lot of your problems with regard to screening. So we had one case where we had an increased NT, one case where the NT was normal, but there was an abnormal biochemistry. Like still does,
just one comment, that everyone's perception to risk is also different. You know, like 1 in 89 may be high risk patient. There can be some patient who may say that, okay, you know, it's coming to nearly only 1.5%. So I think
Sir, I think you're very right at that. That's why we are using that spread of like less than 1 in 100, 1 in 100 to 1 in 999, and more than less than 1 in 1000. So that is what we have to arbitrarily make. But like Madam said, 1 in 89 is also 88 out of 89 will be normal under those conditions. So the way we explain to them that if this test had not come into the picture, you were 1 in 500, now you've become 1 in 89. So although the possibility of being normal is still higher, but the possibility of being normal was much higher before we did the test than what it is now. So basically, when we counsel them in different ways, we also get the right words. And that's the message, that because there are 500 odd people listening to us here, and it's always that what do we tell the patient? The moment we use the word risk, they become scared. The moment I tell them it's high risk, it becomes. These are the common problems that people have while counseling patients with aneuploidy.
And at the same
test.
time, low risk is not no risk. That
Absolutely.
should also be a part of
And that's what Ratna
the
ma'am
other
said in the
side.
beginning, that before they embark on the whole process of screening, let them know what is the limit. And if they want a test which has a higher like detection rate, or if they want a test which covers much more than what you do in a conventional thing, that's a choice they have. Because just because your protocol is to do only combined test, if a patient wants to do an NIPT, it doesn't stop us. But then would you give up the scan for the NIPT? No, you won't.
No.
So you will give the whatever is the best for the patient and make out, okay, for you, with your expectations, with your ability to put in resources, maybe this will work out better. So we need to have some cafeteria approach for our patients as well, because we are in a system where the patient can choose to pay for a particular test and take a particular test. So if she's able to do that, let's give her this approach. If she's not able to do that, let's give her what is the standard approach for most of our patients. So I think these are two cases which represent two conditions which I think most of us face, and therefore some messages have been taken. But like I said, life doesn't become easy. So while we were thinking we've understood everything about screening, nothing can go wrong. Praveen sir, Mrs. L comes to you and she's really worried now because she has twins. 12-week scan was done. NT scan was normal, but now again double marker says high risk, and she's really panicking. Now, what is the most important question you're going to ask her?
First and foremost thing, I need to evaluate the chorionicity. Because
what is chorionicity, sir?
Yeah, what is chorionicity? Chorionicity is the number of placentas, let us say. But when first trimester, that is the best time to assess the chorionicity, wherein the number of gestational sacs are equivalent to number of chorions. Another important thing is that once you have demonstrated that it's a twin gestation where you have two gestational sacs separately, then you know that you are dealing with a dichorionic diamniotic twins. So, but once you go into the second trimester, probably you need to be much more careful in the sense there is a possibility that you need to identify whether that placenta is being shared or is being fused. So in order to differentiate between a fused placenta and a shared placenta, fused placenta is one where you have two chorions which are fused together, which is identified by what is called as the lambda sign or the twin peak sign. Whereas if it is a shared placenta, you have only one placenta which is shared by both the twins, and there you have what is called as the inverted T sign. And these are the things which will tell us about the chorionicity. But in the first trimester, basically we always go by the number of gestational sacs, and number of yolk sacs to some extent tell you about the amnionicity. So I think first and foremost thing I would be interested in is identifying the chorionicity of these twin gestation.
The report only said twins.
No. Then put it in the dustbin and redo the exam.
So this is another thing. There is no report of twins in fetal medicine scans. If you claim to be a fetal medicine person scanning fetuses, you have to report either monochorionic or dichorionic twins. And the chorionicity has to be an integral part of the scan report, because any discussion in twins, even before we discuss what went wrong in that case, started with chorionicity. So that's the first and foremost method to take. Dr. Aparna, are there any other points you'd like to check before you commit your advice based on this report of high risk?
Yes. So I think, first of all, I would like to know whether the forms were filled properly or not. Like, sometimes, we fill forms, but, the entries are not done. So most of the time, the labs do not know that it was a twin pregnancy. Because
is that common? Do you see that?
All the time. So that's very common. So because, we have to understand that there are two babies there are two placentas in there. So obviously the markers would be raised. So beta HCG would be raised. So in that situation, the corrections are there. The studies have shown that for any twin pregnancy, there is a factor by which the beta HCG has to be divided, which is around 2.0 something. And for the PAPE also needs to be divided. And the PAPE depends on the chorionicity. So when we are actually filling the form, so it is not just the twins, but chorionicity also needs to be mentioned on the form, because the factor by which the beta HCG and PAPE needs to be adjusted, it depends on the twin pregnancy and chorionicity. So these two things have to be mentioned in along with the other details.
So like you said, do you look at that report before you talk to her, whether it's high risk or low risk, and you look at that part? Because if you see the common reports, there is a number of fetuses column there.
Always.
And very often we see that that number of fetuses is always saying 1, although it is a twin pregnancy. And obviously, if it is 1, nobody bothers about chorionicity thereafter. So, like we said in NT, look at the NT, whether it's been taken correctly, look at the millimeter, centimeter story, whether it's been given correctly. Similarly, in twin pregnancy also, you need to actually look at that report carefully. Now, this is what we are talking about may not be, you would assume if somebody is working in a very structured system, they may assume, oh, this is understood, this is what is the, but in the real life scenarios, I'm telling you, we face this very often. Chorionicity is not mentioned, and in the biochemistry, twins have not been taken into account, and that is the reason why things have not been taken correctly. So the scans must mention chorionicity, and the biochemistry must include the twin status along with the chorionicity. Now, Bimal sir, okay, we mentioned chorionicity also, we mentioned twins also, but the 2 fetuses had 2 different CRL. You told us that the NT is a function of the CRL, so we mentioned. Now, 2 fetuses have 2 different CRL. How do we date this pregnancy? Because biochemical interpretation will depend on dating of the pregnancy. There are 2 fetuses with 2 different CRLs.
Before I come to dating, there are 2 very important questions I would ask right in the beginning. One thing is whether it's a natural conception or it's an IVF conception. That is a very, very important point which needs to be added.
Whichever way it has been conceived, now there are 2 babies.
No, I'm talking about adding in the form. It's a very, very important thing.
Sure, we've done. Okay, that is done.
And secondly, whether it's a donor or it's not a donor. That is, again, because that is one thing which, along with the chorionicity and all, the biggest problem at the moment is that most of these are donor pregnancies and we don't know the donor age. So then, these are 2 very important questions.
Okay, age, mode of conception has been sorted out. This is gestational, let us call it an IVF pregnancy with self-eggs at the same time. That is done. Now, how do we date? The CRL is different. My problem is their CRL is different.
Exactly. Now, as far as dating is concerned, if it's an IVF pregnancy, we would date by the embryo transfer dates, But okay, if it is not one, then now I have 2 CRLs which are different. Now, I would, there are 3 ways. Either you date it according to the larger fetus or the smaller fetus or a mean of all the 3 fetus. Now, there have been studies which have said that the dating by the CRL of the smaller fetus is the one which comes more closer to the accurate gestational age. But it is, accepted that we need to use the larger fetus for determining the CRL of the larger fetus to assign the gestational age.
So if you have twins and one has a CRL of 52 millimeter and one has a CRL of 58 millimeter, you will date by what
58,
CRL?
58 millimeter.
58.
Yeah, because
so you have decided that you will date by the larger fetus. There are studies which say smaller is good. There are studies which say average is good. But as of now, the guideline stands at dating by the larger fetus. So NT for each fetus may be considered in the centile of its own CRL. But when it comes to biochemistry, you will be using the date as per the larger fetus. And therefore, biochemistry centiles will be estimated
based upon the gestational age.
Based upon gestational age of the
as
pregnancy.
per the larger CRL. Yeah.
So now, madam, we have twin pregnancies and we are now a little confused. We have dated them. There are 2 people. There are 2 different ways. How do we assign risks to them? I mean, this is just one pregnancy.
So for monochorionic twins, we assign 1 risk. Now, because we are in the first trimester and we have got 2 NTs, we can assign the risk for dichorionic twins. There are 2 risks, and these are based on both individual risks for both the fetuses. So that is very important to see in your report.
Why is it, ma'am? Why should monochorionics have 1 risk?
because they have one placenta and they started as one zygote. Okay, they started as one egg and one sperm. So genetically they are the same. Whereas dichorionic genetically are different, and that's why you have to assign 2 risks for them.
So when we have a discordant NT in a MCDA pregnancy, they have 2 different nuchal translucencies. Dr. Aparna, Dr. Ratna says we have to give them only 1 risk. And this is an MCDA pregnancy with 1 fetus having 4.2 NT for a CRL of 56, 1 having 1.8 for a CRL of 54.
Yes. So we have to think of other causes of a discordant NT or a discordant CRL. So we know that monochorionicity is a high risk factor for other things as well. Like
no, but what do we do about aneuploidy? I mean, we have to give them just 1 risk.
Yes.
And we have 2 different NTs.
Okay, so we calculate the mean NT. So we calculate the mean.
Here it's not the larger, it's the mean. So even if people think it's 10 o'clock and we're kind of switching off for the day, you still need to be awake and listen that for the CRL, Dr. Bimal said it is the larger CRL with which you date the pregnancy. But for the purposes of risk calculation in an MCDA, where you're going to give only 1 risk to the entire pregnancy with 2 fetuses with discordant NT, it has to be an average of the 2 NT. So if, like Dr. Aparna was saying, there could be other reasons for discordance of NT in MCDA, that's a different story. It could be an early marker for DGTS. But as of now, if you have 1.8 and 4.2, you will consider 3 as the mean, and you will give a risk of aneuploidy based on an NT of 3 for whatever biochemistry has been calculated for an monochorionic twin pregnancy for that brain, and you will get only 1 combined risk for both the fetuses because it is monochorionic. Whereas if it is dichorionic, then what do we do, Dr. Aparna?
Dichorionic, the risk is calculated individually, like for each of these babies. And so how it is taken is that for twin A, the risk is this much. For the twin A, the risk is this much. The biochemistry is taken as, so it's something called a pseudo risk, which is given. So you have for a twin A, for this particular age, NT and biochemistry, the risk is this. And for twin B, the age, NT, the biochemistry, the risk is calculated as this. So that is the difference between a monochorionic and a dichorionic pregnancy.
But I have a little confusion. Are all dichorionic pregnancies genetically different?
So that depends on the time of separation. They could be similar, definitely. But
they could be similar, but now you're giving them separate risks. So are we doing something wrong? Are we missing something?
But we have to take, so we have to take that risk if because they are 2 different sacs. So yes.
So why I raise this is because we are not actually missing anything here, because if you see the 2 conditions where we took the monochorionic condition, the highest NT that we had was 4.2. But because we combined them, we got 3 as the mean NT and the risk calculation was done at 3. Whereas in a dichorionic, if we are taking them individually, we are taking the risk calculation at 4.2. So the risk is going to be worse than what it would have been if we had combined the 2. So we are not actually going to miss out anything by doing this, because we'll only get a higher risk for even a supposedly monozygotic pregnancy. Suppose it was monozygotic which carried on. So it doesn't make a difference, because we often get the question that, oh, you are taking zygosity, chorionicity as a surrogate marker for zygosity. Are you going to miss out something? You're not going to miss out.
You're not.
The only thing that's going to happen is you probably will overestimate this risk if you did not know the zygosity, which is not a problem, because you are going to and that's the only reason you have to test both the fetuses whenever you get a high risk result in a dichorionic pregnancy as well. So I hope that message goes across. So in first trimester ultrasound, if it's a monochorionic pregnancy, you take an average NT of all the fetuses involved. If it is polychorionic, individual risk. And this applies for higher order multiples also, it will be the same. Madam, NIPT again.
Yeah, so you can do an NIPT in twins. It's important to remember it doesn't differentiate. It will not give you 2 risk estimates.
So how does it work exactly for twins?
So so there are 2 ways of doing NIPT, the SNP based and the MPS based. So when you do the SNP based, there is a possibility of separating the risk, but in the MPS based, you cannot separate the risk. So whatever If you get a low risk, it's a low risk for both twins. If you get a high risk, you have to end up testing both the twins.
But it still works because, like I've just put down here, that what are the three possibilities with twins? It's either both are normal or both are trisomic, or one is trisomic and one is abnormal. So I'm presuming that in that discordant group, you will get some discordance in the result. So you may end up picking high risk and not being able to tell whether both are trisomic or one is trisomic, and therefore you need to test both. Whereas if it is low risk, you can sort of rule out that possibility in both of them and avoid an unnecessary invasive procedure.
You may need to do an additional procedure for a twin who's not affected, but you won't miss an affected twin. True. Because of the fact that they are twins. Because of the fact that they are twins.
True, ma'am. And that would be the same with our conventional screening as well.
Yeah.
Because even in that, if it got a high risk, we were entitled to check both of them. So if we ever reach a condition of invasive testing in twins, we are anyway mandated to test both the twins. And therefore, whether we achieve it by conventional screening or we achieve it by NIPT, I don't think it's making a difference in that decision of testing. So there is a rationale.
And actually, the only advantage, I mean, one advantage of NIPT versus a combined first trimester is the lower false positive rate.
Absolutely.
So the number of procedures that you would do in a twin pregnancy would be much less.
Significantly. So there is evidence now. This is the ACOG practice bulletin, and it says, yes, NIPT can be used for twins. And in fact, the sensitivity for trisomy 21 is as good as that in singletons. So there is a rationale of using NIPT even in twin pregnancies. Whether you should give up conventional screening and do NIPT will always remain that question. Under any circumstances, we are not giving up the scan in the first trimester. It's only the role of biochemistry that changes. But I mean, if you use it rationally, there is a role for each and every screening test, as long as you can place it at the right place in that entire hierarchy of tests.
And the right gestation. And the right gestation.
And the right gestation. So, Praveen sir, this patient came to you and you just bumped her at curiosity. Yes. But now, can you give us all the take-home messages for twins?
Now, whenever we are trying to evaluate multiple gestations, there are 4 factors which all of us have been telling. One is that first and foremost thing, we need to ascertain the curiosity. Second most important thing is that the largest CRL has to be taken in dating the pregnancy. The third important thing is once you have differentiated it as DCDA or MCDA, in DCDA, what we are trying to do is we are going to individually test each of this. That means you are testing the fetuses individually, whereas in an MCDA, you are testing the pregnancy as a whole. So these are the few most important things that we need to take home. And then NIPT has definitely as a role to play even in a multiple gestation as good as in a single gestation, singleton pregnancy. So will that be fine? Yes.
Yes, sir. I think that's very clear, and thank you so much. I think our panel has been extremely clear in their messages, and it's a privilege to have such an eminent panel here to answer these questions. So from the point of view of the 3 case-based discussions we wanted to have this evening, we've completed that aspect, and I see some very interesting questions in the chat box. So I think we should move on to that. And sir, I now hand it over to you. And we need to take care of some of these questions.
Yes, thank you so much, Chinmay. And of course, it was an absolute dream team to have this as panelists. We plan to have this particular program for which we have joined up with the Raipur Obs and Gynae Society as a monthly program, like I said, with the idea of having not the usual young talent that we always try to push into our programs and make sure they reach their maximum potential, but as an expert program so that people can have their questions answered. And we will proceed to answer all those questions. But before I proceed
just
to that,
break in here, sir. Winston Churchill had that art of conversation where he said, you can tell people to go to hell so that they look forward to that journey. You just told a set of people that they are old in a way that
no, we're very good. But I really want to congratulate Dr. Asha Jain and Dr. Tabassum Dalla for thinking about this program and for helping us to partner with the Raipur Obstetrics and Gynecological Society.
Thank you, sir.
They're wearing two hats. They're wearing the SFM hat and they're wearing their local gynae chapter hat, which is fantastic.
Which is on the top.
And no, they're side by side. We always work side by side. And we'll now proceed. We had over 500 participants at the time today, which is really fantastic. And I can't believe that a regional meeting can have more than 500. That's absolutely phenomenal. There have been questions on when will we have this available. We check copyright issues and then decide to put it on our YouTube channel, but that takes about a month or more, and hopefully we will. But we have some really nice questions in the chat box, and I'd request Dr. Hasmukh to now take over these questions and address them. May the panelists please stay on so that we can answer these questions all together. Dr. Hasmukh, please. You have to unmute yourself, of course. Dr. Hasmukh, you'll have to unmute yourself and proceed with the questions.
It's nearing 10.
That's actually, sir.
There we are. Yes.
The question here, one I can read is NIPT in twins. Fetal fraction may come more from one twin, and if it starts low risk. I think this is somebody has given the answer.
You'll have to be a little louder, Dr. Hasmukh.
Sir.
Yeah, there we are.
I think you can start a few of them, Ashok.
Yeah, I think the one question that needs to be covered before we shut down the panel, etc., is the question of the vanishing twin. So, Dr. Ratnapuri, can you please tell us how do we handle the vanishing twin for aneuploidies, screening and diagnosis?
Usually, if there is a vanishing, if there is an ultrasound which shows a vanished twin, NIPT is also not a good idea, as is the biochemistry. You usually rely upon the ultrasound, the nuchal translucency and all the additional markers. Because at least in NIPT sometimes, so most of these vanished twins would be aneuploid, and they would come up with the bizarre patterns on the NIPT, and unnecessarily that would result in an invasive procedure.
But these companies keep telling us, look, if it's 6 weeks, if it's 8 weeks, we'll manage.
Well, I know they tell us it's about 6 weeks, 8 weeks, that probably the DNA will not be there. It would have disappeared, because we know that after the birth of the baby, the DNA does not stay.
Yes.
But I have never read it anywhere in any guidelines, and the guidelines just say that, you do not do it if there's a vanished twin. And I also know that sometimes when you get a bizarre NIPT, that means you get a screen positive NIPT and you do an amnio, one of the reasons is a very early vanished twins, because they did do studies early when they were doing a lot of studies on NIPT, and they would look at the placentas, and they did screening on various sections of the placentas, and that's where they found either CPM or they found a very, very early vanished twin, which gave a false positive NIPT, even before you could see it on the ultrasound.
So
the recommendations are that you do not do.
Scan.
Sorry?
Yes. So we'd rather depend on a good NT evaluation more than anything else. Yes. Dr. Hasmukh, if we could take over the questions, please.
Sir, I don't know where are the questions here. I mean,
in the chat box, in the same chat box.
I cannot see the whole chat box. The initial.
Sir, may I take over?
Yeah. Actually, Dr. Asha, if you can see, please go ahead.
Yes, sir.
Yes.
Sir, FMF guidelines say, Dr. Sasmita Das is asking, FHR should be used in low risk calculations, but our labs don't use it. How to go about it?
The fetal heart rate.
Yes.
They all include it. They're all supposed to include it.
They're supposed to include, and if they don't, I think everyone has to use the FMF software directly.
Yes.
So either you can use it on the FMF website where there is a place to do the risk calculation by entering your values, or please try and get your certification so that you get the software for your personal use where you can put in all the values that you want. So
or
on
choose a lab that includes it. Yes.
Yeah, or take a lab that includes it. Absolutely.
Dr. Niharika is asking, significance of PLGF and NIPT. Please include interpretation of double, triple, quadruple markers in one of the sessions. So I think that is done.
We will do that in the future in more detail. Yes.
So
and then we have some very interesting questions on how should we proceed from step A to step last. And Dr. Ratnapuri, can I address this question to you while Dr. Asha Jain puts together some of the other questions? So the patient is here with me, and she is today at 12 weeks, 2 days. Which test first, which second, which third? How do I reach exome sequencing, and how do I reach fetal echocardiography? And then what do I do? I know I'm not giving you too much time, but
Okay.
step one to step last, as simply as you always do it for us.
So step one is you would do your nuchal translucency and you would do the combined first trimester. No, sorry. Step one is you take a family history and you would do a pre-test counseling. If it's a low risk family, that means there's no other family history and they're just having their first baby and all is good, you would do a pre-test counseling for the combined first trimester screen, which means the nuchal translucency, the PAPE and the pre-beta HCG, with the correct date of birth and all the other maternal characteristics. And then you would guide them. If it's low risk, you would just follow up with a second level ultrasound between 18 to 20 weeks, where you would look for soft markers and structural abnormalities and fetal biometry. However, if it comes in the intermediate risk in the first trimester, your screen, you would add either the additional markers or you could do an NIPT. If it's a high risk, you have two options there. Either you would offer directly the invasive test to look at the chromosomes in a chorionic villus sample, or you could offer a NIPT depending upon what the risk factor is. If something comes as high as 1 in 5, 1 in 10, please go ahead and do an invasive, unless it's an IVF pregnancy and things like that. It's better to do an invasive in really high risk situations, 1 in 20, because here there is a higher chance of identifying structural abnormalities of chromosomes. If you have done a first trimester screening, you are happy with it, it's low risk, there is no role of doing biochemical screening in the second trimester. So you would not do a triple test or a quadruple test. If you have an intermediate risk in the first trimester, even after you've done your various additional ultrasound markers, you could do that integrated screen. That means you take the final risk of the first trimester screen, use that as the a priori risk and not the maternal age risk. You use your first trimester screen as an a priori risk, do the quadruple test, and you get an integrated result, which has a very high sensitivity. And if that also comes screen positive, you would do an invasive test. And you would want to screen your women at 16 weeks, not at 18 weeks after the level 2 scan, because then by the time you get your results, it's 20 weeks and there's panic. There is no role based on all this. If all this is fine, it's a low risk situation. However, if you have structural abnormalities or you have a high NT of 7 mm and the chromosomes are okay, you could look at some of the genes. I would not do a exome sequencing. I would do a limited panel testing for rasopathies. So that's how you would use the tests in pregnancy.
Thank you. And then there's two groups of questions, and one of them I'll answer because I think that was for me. And that is this question of the cutoffs that we use in our counseling. 1 in 50 or less, 1 in 50 to 1 in 100, 1 in 100 to 1 to 999, and then less than 1 in 10,000, 1 in 1,000. So Kypros Nicolaides decides this every year in the summer. And, he's the godfather of fetal medicine. We don't argue with him, because he has the statistics to support all this. And what they do about cutoffs is the basis statistics. How much are we likely to miss and how much are we likely to pick up? So currently, he is quite happy at using 100 as the differentiation between high and intermediate. And less than the 100, he divides into two categories: very high, which is 1 in 10 or so, and then the rest. But this business of 50, 100 or 250 as the cutoff between the high risk and the intermediate, he tends to change every year. The idea really is how much invasive do you want to do? How much risk do you want to put people through? So a lot of us now over the years have realized that figures don't mean much to our patients because they don't even know what is the risk of leaving the house and not reaching home at night. After all, there is a risk in leaving home and not reaching home at night when they're out on the road. So therefore, we don't use cutoffs too sharply, but typically a lot of people now using 250 as the cutoff for this high risk and not so high risk. And I like to use 50, other people like to use 100. So it's your personal choice. The next question is actually, I want Dr. Aparna to emphasize this, the difference between NTs between the 95th and 99th, and should we ignore them? And the difference between the 99th centile NT and that famous cutoff of 3.5 millimeters of the NT. You'll have to unmute yourself. Yeah, there we are.
Yes. So thank you, sir. I think there's a basic difference between the 95th and the 99th percentile. So if we say that, so whenever we are trying to look at an increased NT, we want to know what is the risk of aneuploidy, what is the risk of infection, and what is the risk of residual anomalies like other chromosomes or rasopathies, as ma'am is talking about. So what are the chances beyond? So when we talk about an NT which is more than 99th centile, we're talking about an increased risk of structural anomalies, increased risk of residual anomalies. So it has been seen that if you are testing beyond the 99th centile, the chances of the babies having major defects is much more than if it was more than the 95th centile. So just to give you a very, very simple number. So if you choose to undergo, say, an NIPT screening for more than 95th centile, the residual defect that you leave is only 1%. But if you choose to go for NIPT beyond the 99th centile, the residual defect or the syndromes that you're missing out is more than 3 to 5%. So that is the difference between a 95th centile and a 99th centile. And also, like, for example, you do a biochemistry. So if you offer biochemistry for somebody who's more than 99th centile, then 95% of the time that biochemistry is going to come positive. So these are some basic differences. So more than 99th centile, you assume that there is some problem, and you need definitely that those tests which are more invasive, definitely you go for invasive testing, and those processes that we have described. Between 95th to 99th centile, just think about it again. What is the risk? Is it an IVF conception? Is it a very precious pregnancy? You counsel that patient again that, okay, between the 90th to 99th centile, the risks are not as much as you would expect beyond the 99th centile.
So
Thank you.
basically what we need to take into consideration is anything more than 99, and a definitive diagnostic test has to be done. Between 99 to 90, 95 to 99, I think probably we still can do an NIPT and then channelize our resources based on the NIPT results.
We'll pick up more with more false positive. The false positive would be less with a greater than 99 centile.
Yeah. And then one question was about the PI of the ductus venosus compared to just a reversed AVIV compared to an altered PI. So we know that the forward flow in the AVIV is related to gestational age, of course. And so we use a gestational age related PI because unlike the first formula that we came up with 7 years ago, we know that for the last 5 years, we now use the PI because we don't wait for the reversal. So that becomes extremely important, and it should be always gestational age related. Then there is a whole group of questions.
Sir, can I ask one question in the meantime?
Yes, Bimal.
Yeah, this is in continuation to the point that I was making during the panel discussion, and now with Ratnapuri ma'am here and Chinmay and Aparna all here. I was talking about the donors. The real life situation is that suppose there's a 42-year-old female who has come for a scan. They don't inform that they have a donor, they're using a donor egg. Very, very common scenario. You ask the patient, you look at the husband will look at her, they will say, no, no, no. Second point is you call the IVF lab, most of the times they would not provide you this information. So how do you screen such patients? In the sense, how do you go about it? And I think majority of them would be facing this situation.
Sir, I would like to come in here because we get a lot of these IVF patients. There are two simple facts, sir. If she is not revealing whether it's a donor or not, by default, she'd be an older person who doesn't want to reveal that she's taken a donor egg. That's not a problem for us because we are going to use her age as the screening baseline, which is going to be on the higher side. So if at all, we'll get more false positives, but we are not going to have false negatives. Once we reach that situation where it is a false positive, I mean, assuming it's a false positive, then when you have that second level of counseling, the post-test counseling, where you sit down and explain to them that this risk is coming because of the age of the mother, 50% of them are going to yield that, okay, there was a donor. The other problem we have was that the donors are not regulated in some labs, so that the labs don't give us the exact age of the donor. They say, yes, it is a donor, but we don't know the age of the donor because the lab never told us. And in that situation, what we take is a cutoff of 27 or 28 years because IVF centers do not use donors above that age. So we ask that particular center that what is the maximum age of the donors at your center. If they say 28, we stick to 28. If they say 27, we stick to 27. And we give them that as the age of the donor.
So you don't take it written from them that this is the age of
It's
the
not
donor.
practical, sir. What you're saying is an ideal thing, but in many centers that doesn't happen. And like you said, many people want to keep it confidential. So if they keep it confidential, they keep it at their own risk because we tell them that suppose you're not telling us that, it may be that you will have a higher risk based on your age, because the situation will only arise when the biological mother has an age higher than what we expect of a donor.
Yeah, because if she's 41, 42, whatever comes the reading, she's going to land up into a high risk.
So practically what happens is in the second sitting, they come and tell us that, okay, it was a donor. Then we contact the lab, we get an age and then we recalculate. If it's still bad, then we go for NIPT.
Isn't it simpler to directly call up the fertility specialist and ask her?
They
We
don't
do,
answer.
but sometimes they don't have, sir. Sometimes they don't.
No,
Most of the time, they don't inform.
Confidential.
Yeah, they don't inform.
They do provide. I mean,
Also, our profile of donors is such that they really don't know their date of birth.
That's also true, sir.
So if you call the lab, it's either 27 or 32 years. I rarely got a third answer.
I won't say donors. I think majority of the women here would not know their correct date of birth. So
That's marvelous. We have covered.
So there's one question.
Yes.
In a case of double marker, cutoff value of PAPE is higher, but other two are normal. How to interpret?
Which two are normal in double mark?
So not the cutoff, but the mom value. Yes.
Yeah, the mom
I guess
value.
that
That's
was the
one.
question must have been. Yes.
High PAPE is not a problem.
has no meaning.
No,
It has
no.
no, I mean, no significance.
So, no.
Very
I
good
think
plus.
first thing we need to tell them is that in a euploid, the mom is take one as for both beta HCG as well as PAPE. I mean, based on that, if it is double beta HCG and half PAPE, that's when we are worried about.
Does fetal exome sequence include Rasopathy's gene panel?
So remember, when you do even a patient, a postnatal patient's exome sequencing, we come up with such vague kind of, at times, variations of unknown significance that we have to go back and reverse phenotype the patient. So in a fetus, in an ongoing pregnancy, where we do not have any phenotype, we would not do an exome sequencing, at least as of the current times. We may become more intelligent later and we would be able to offer it, but as of now, we cannot. Like I said, there are indications of doing a Rasopathy panel. There are many reports now as recent as 2019 and 20, which tell us, say if your NT is more than 5 millimeters and you have not identified any abnormality in the chromosomes, or there are additional features like say a pleural effusion or a cardiac abnormality and things like that, you would do a Rasopathy panel. The reason for that is it's a limited panel, but just go back to your lab and ask them, are all the genes that are identified for Rasopathy, they are up to about 18 genes, are they all included in the panel? Sometimes the panel is old, it does not have the new genes, and that's not a bad idea. If for some reason the panel does not have some of the newer genes, then you would do an exome sequencing and just read off the genes for Rasopathy. That's what I'm trying to say.
On 9th of December, Madam is speaking on exome sequencing. Is that right? 9th of December?
Yes,
Yeah,
I'm
yeah.
only speaking on one part. One of my
Yeah.
students is speaking and I'm just talking about the challenges.
Right, because
So,
the first thing is Noonan was, in case of chromosome is normal, Noonan, and then the other rhizopathies. And
yes. So
polyhydramnios.
we test them together. Yeah,
Polyhydramnios is the significant finding in that actually.
We have a minute for a quick answer to two questions which are repeating themselves. One is, only the nasal bone is absent. What do I do? Only the ductus venosus shows an abnormal PI. What do I do? Anybody on the panel, please.
Always look at the entire picture.
Yes.
Always look at the entire picture. And because when you're screening for aneuploidy, there's a reason everything has been used in the armamentarium, because no single marker is better than all of them put together. So when you look at aneuploidy, look at each of them separately. If you're looking only at absent nasal bone and it increases by 6 times and that brings your final risk into the intermediate risk or the high risk group, then act accordingly.
Yeah. And Bimal, what about the PI in the ductus venosus?
As an isolated finding, yes, I mean, I would look at the heart in a better way. If I'm routinely not doing a transvaginal, I would do a transvaginal and look at the heart at this stage, and also ask for a 16 weeks cancer.
Yeah.
For an early fetal echo.
And all these things we would be covering up in future programs, because Dr. Asha Jain has a whip on me and she's made sure that I will carry out a good thing with Dr. TLN Praveen and me, and all of us put together on the executive committee will put together the topics for the next one. And I promise you, we will take you from A to Z in the same way. And now back to Dr. Asha Jain for our closing remarks, please. You have to unmute yourself, Dr. Asha. Yes.
Thank you, sir, for an excellent academic feast. All of the SFM dignitaries here, and I won't even dream of holding a whip to your head, but you are kind enough to accept my request. It was my, earnest desire that Raipur Obstetric Gynec does something on a long term so that gynecologists really learn. So,
yes, and thanks to Sir for this.
Foxy is already doing a course, but that is a paid course and that is very labor intensive, 3 hours per week, for 12 weeks. Not everybody is going to attend. But this 1 hour, one evening in a month is good enough, and you have consented to it. So thanks a lot. And Tabassum, you can take over, I think.
Yes, ma'am.
Go ahead.
On behalf of Society of Fetal Medicine and Obstetrics and Gynecological Society, it's my pleasure. Dr. Krishna Gopal, Chinmay ma'am, excellent moderator as usual. Our panelist, TNL Praveen sir, Ratna Dipuri ma'am, Bimal Sahani ma'am, sir, and K. Arpana Sharma ma'am, and also Dr. Asha Jain ma'am, who took all the pains to organize this today, and all the dignitaries who joined today. I also would like to thank the trade partners, GE and Lifestyle Diagnostics. So thanks each and every one of you, and hope you enjoyed each and every part of it. And we look forward to see you all again next Wednesday. Thank you
January, first Wednesday of January, evening 8 p.m. So goodbye till then.
Goodbye.
Thank you.
Okay.
Thank
Good
you.
night. Good night, and thank you all.
Night.
Thank you all. Yeah.
Thank you.
Goodbye. Thank you. Bye-bye.
Thank you. Thank you.
Thank you. Bye.
Bye-bye.
Thank you, sir.
Bye.